we have to realize that incomplete revascularization and low post-PCI physiology are surrogates of the extent and diffuseness of the disease. The most important determinant of FFR or physiology after PCI is the pullback curve at baseline. Imaging, as shown by the doctor study, has a minor impact on post-PCI FFR, and mirroring pre-PCI physiology, the mechanisms leading to suboptimal physiology after PCI should be elucidated by pullback and differentiate between focal jumps or diffuse residual pressure loss. And to conclude this, I'm sure we have to say that there is an unmet need in quantifying the pattern of functional disease.
As you can see, there is a significant stenosis in the proximal mid of the LAD, and the distal part or distal mid of LAD, there is also some stenosis, also diffuse disease. So we checked the pressure gradient, and DPR was positive, 0.86. And as you can see, it's an example of diffuse disease. But the pressure gradient is mainly caused by the right half of this picture. So it means the proximal half of the LAD. So we decided to treat this half by perilatation. On the left side, you can see the stent implantation. This is uninflated stent. And in the right picture, this is already implanted stent after post-dilatation. And the final DPR is 0.96. So it's a proof that the hemodynamic significance and pressure decrease was caused just by the proximal stenosis and then the distal one.
I did this post-PCI DPR, and it was 0.75. I was quite surprised by this. And I wanted to see where is the flow limitation. I did a pullback, and the pullback curve showed me that there was a gradual increase in pressure towards the ostium of the LAD. So now what to do? Is it because the stent is not expanded, or what is the problem? I decided to do an OCT, and OCT showed me that I had a good stent expansion. The expansion was 102%, but there was a proximal edge dissection in the ostium of the LAD. So this showed me that the pressure showed me that there was something wrong, and imaging showed me where the problem was.
In this study, 183 vessels from 163 patients were allocated to either IFR pullback assessment, RFR pullback assessment, and DPR pullback assessment in Gifu, Toyohashi, and Nagoya Heart Center. By PCI, all of the non-hyperemic pressure ratio improved significantly, as shown in this slide. The pre-PCI predicted NHPRs had a strong correlation with actual post-PCI NHPRs, as shown here. The difference between pre-PCI predicted and actual post-PCI NHPRs were IFR 0.02, RFR 0.01, and DPR 0.02. Prediction of functional PCI results based on pre-procedural RFR and DPR pullbacks yields similar results to IFR in terms of PCI strategies. Compared with angiography-based PCI planning, a pullback-guided PCI strategies with any of the three NHPRs reduce the number of stenosis and the total length of treated lesion.